How's everybody feeling? Good. I heard someone turn on. Thank you. Yes, I know I think this is our last workshop before we have our closing keynote. And so thank you for being here. Some of you got to sit in earlier in a presentation that I participated in. So my name is Cynthia Garcia, and I'm a licensed mental health counselor at FYI, and my focus is trauma. A little bit about me. I've been at FYI for about 3 years, a little over 3 years. And in that trajectory, I've been in a couple of different places. I did start out as an in-home service provider, working for community-based programs. And then I moved up into leadership within that program. And all throughout those years, however, I've continuously done therapy. That is my higher education. My undergrad is in business, human resources, actually, so completely on the opposite end of mental health. I remember I worked for the city, human resources here in Cruces, and I was sitting in my office one day, and it was a very, very, when you look at the clock, kind of like right now, because I'm a little nervous, and the time was just dragging. And I kind of had this feeling like, is this what I'm going to do forever? Human resources. If you've ever worked there, shout out to you. However, that's not what I wanted to do for the rest of my life. And so I am very privileged to have a very supportive husband who was like, let's do it now. Go get your master's. And I will recognize at all times the privilege that I had to be able to seek out higher education. So went and got my master's degree in clinical mental health counseling here at NMSU, and my heart is in half because my undergrad is at UNM, and my grad was from NMSU. Some of my best years, I think, were my undergrad, so I'm torn between a Lobo and an Aggie. Please don't get me after this presentation for saying that, but it's the truth. And so I've been practicing therapy, and I am by adoption, I say. I'm a social worker. I was immersed into social work, and I couldn't be more grateful for that, actually. It definitely redefined how I view therapy, how I defined therapy. It is very much the common reality to think of therapy in an office setting and in four walls. And I was very, very privileged, very hard, but very privileged to have been able to bring these therapeutic interventions inside homes, real lives, real stories, real circumstances. And so today I'm going to be talking to you about trauma-focused cognitive behavioral therapy, and how does that in any way connect to child maltreatment? How is that, and how do we bridge the gaps in the aftermath of child maltreatment? So these next couple slides, I just want to make a disclaimer, maybe some of these next couple of slides, and even more so towards the end of the presentation, maybe some of these things might be reminders for you, triggers for you, and so by any means, if you need to step out, completely understand. This work, trauma work, is really hard, and especially in children. So let me just close the door, give me 1 second. So this next slide I'm going to share with you is it's a snippet of a kiddo that I worked with. So I was not allowed to use the restroom outside of my bedroom. I had to ask for food, but was often told no. And so I had to sneak food whenever possible. I guess one day she was having a bad morning and decided to come out and beat me with a pipe. I don't know what I did to make her mad. She came in with a pot of hot water. Different kiddo. We were in a shelter. It felt like a long time. It was me and my 3 little sisters. My dad said my mom left us, but he left too and didn't come back. My grandma picked us up and brought us to live with her. It's her fault we are not with our parents. I had to learn English even though I didn't want to. So what is TFCBT? So TFCBT is an evidence-based treatment. It helps children, or at least the one I focus on, ages 3 to 18. It used to be 17, but there are some studies done that even at 18, it's proven to be effective. It addresses the negative effects of trauma, including processing their traumas or traumatic memories, overcoming problematic or negative thoughts and behaviors, and developing effective coping and interpersonal skills. It is structured and it is short-term. At least this is the design of it, 8 to 25 sessions. It involves the child or adolescent, and their caregiver. It's designed to reduce symptoms of PTSD, trauma-related depression, anxiety, behavioral problems, and common trauma-related cognitive and emotional problems. And I'm going to focus a little bit on that in a little bit, such as fear, shame, embarrassment, guilt, and self-blame. Raise of hands if some of you at any point of your life you have felt one of these emotions. Congratulations, you're human. Now, these emotions, however, in children that have experienced traumatic events, think about that times maybe 100. And maybe your source of shame, guilt, and embarrassment also came from a traumatic event. Although highly effective in treating PTSD, that diagnosis is not necessarily needed for this. They could be in the brink, it could be, just really depends, but it is highly effective for PTSD. Here are some of the goals of TFCBT. To learn effective skills to cope with trauma-related emotional and behavioral problems. And I want to just also be mindful that I think the word coping skills and coping mechanisms, I have kind of heard kiddos throw that out as if it was candy, like my coping mechanism, my coping skills. And I think, however, what gets lost in translation is implementing what is a coping skill or a coping strategy. And what's beautiful about the trauma work we do in the home or with these kids, or whatever setting it is that they get to decide what's going to work for them. In a healthy way, of course, but they get to decide that. Goal number 2, to face and resolve those problems in a safe and therapeutic way. To effectively integrate their trauma experiences and help them move on with their lives in a safe and positive manner. I say this a little bit more lightly, though, the help them move on with their lives in a safe and positive manner. I'm going to give you a little bit of a detour here in TFCBT in the work that I've been doing, because while in an ideal world, yes, we want to help them move on and just become greater, bigger, stronger, more resilient, the reality of child maltreatment is that it's probably going to happen again. And so I want you to keep that at bay, that sometimes when we talk about child maltreatment, especially given all these other complicating factors like their socioeconomic status, their housing situation, their family support or lack of, language barriers. We are a border city. Immigration. I mean, you name it. There's a lot of complicating factors within this trauma that for us to say they're going to gain all these great things in doing TFCBT therapy and they're just going to move on and be the greatest human being ever is, I would love that, but it's not a hard reality at this time. So TFCBT has several components, and it can be said in this acronym, practice. So it stands for psychoeducation and parenting skills. There's a relaxation component. There's affective identification and regulation. There's cognitive coping. There's trauma narration and processing. There's an in vivo mastery component, conjoint child-parent sessions, and then there's an enhancing safety and future development component. Out of these, I'm not going to dive into all of them. I'm going to dive into 5: psychoeducation and parenting, effective identification and regulation, trauma narration and processing, conjoint child-parent sessions, and enhancing safety and future development as it applies to the work that I have been able to do. So, psychoeducation and parenting skills. Trauma, what is it? What does it look like? How may it present? For most of you, I want to say I'm pretty confident that most of you are providers out in the community. So for you to maybe tell someone what trauma is might come a lot easier than to that mother or that father or that grandmother whose grandbaby came because they were sexually abused or sexually assaulted. And they have no idea how this kiddo is externalizing the effects. What's the aftermath of that child maltreatment? They'll walk in and they don't really understand what trauma looks like. So this component of TFCBT is we provide that to the child, adolescent, and the caregiver, parent, because it looks different for a lot of us. Growing up, I was la chillona. I was the crybaby. Everything just set me into tears. My brother looked at me wrong, and I'd be crying. And my mom, I was called la chillona. I reacted differently. That if my brother was in that situation, he'd be like, there's nothing to cry about. I have 2 boys, and one of them, if the other one says no, tears automatically. He said no to me, and the other one. The little one is the one that made the bigger one cry. He just walks away. And it's just different. The bigger one will say no to the little one, and the little one's like, try me, say that again, try it again. We all just react differently, and it's gonna look different for people. And what's interesting is that it's actually sometimes going to look different depending on the situation, depending on who's around you. And so we spend some time educating, really, the child, because even children have a really hard time in identifying and labeling, is this why it feels this way? Is this why I react this way? Is that what that is called? There's a name to that. And so this is super important because it allows me to give parenting guidance to these parents. I work with a lot of immigrant families, and a lot of these families have no idea that there's an explanation to this. Don't get me wrong, there's a lot of cultural barriers too, however, that they're like, no. Eso no. He's 12. He can man up. There's a lot of that still. And what I love about TFCBT, or at least in my practice, is that, okay, I'll meet you where you're at. What does that mean? He's 12. He can man up. So lots of parenting guidance in this model. There are strategies to manage disruptive, aggressive, or non-compliant behavior. Some of these words I'm not a fan of, and/or fears, sleep problems, and inappropriate sexual behaviors, because although at kind of the surface level, it's let's just help you kind of cope with and deal with these behaviors, we take it a little bit deeper to not just kind of handle and manage these certain behaviors. There's a reason for why it's a miscue. There's a reason why these behaviors are coming out, and so we're going to work on not just the surface. We're going to get under that, and I'm going to meet you, Mom. I'm going to meet you, Dad. I'm going to meet you, Grandma, where you're at, literally and figuratively, and we're going to kind of tease that out. Sometimes it's a little quicker than in other families. Again, really taking into consideration the cultural aspects of that. There's a lot of guilt and shame, so it kind of shows up as overcompensation or avoidance in our families. So guilt and shame of how could that have happened under my roof? How could that have happened to our family? I can't believe that happened. It happened to me and I didn't say anything and I turned out okay. Well, but it happened to my kid. It happened to my grandbaby. And there's so much guilt and shame that comes out of this. So then the parenting component of that is also helping the caregiver. And again, it doesn't have to be the mom or the dad, or it requires hope. For it to be the most effective, we can have at least one supportive caregiver. It requires for them to do that work too. So we come alongside in a parallel in this practice. So the effective identification and regulation. So when kiddos have experienced traumatic events, They experience intense levels of negative emotions, sadness, anger, fear, anxiety. We already said guilt and shame and disgust, but then these are exacerbated. These are just blown up and they're very intense. And then that's when we get grandma saying, well, just punching the walls and throwing things. And if he would just act right. You know, we get a lot of that too. I hear a lot of that. But there's this, the gap of, I don't know how to deal with this sadness and anger. You didn't teach me that. You didn't show me that. Well, that parent or caregiver was probably not modeled that either, was not taught that. So again, the identification and regulation for the child, but also for the parent. Difficulty identifying, understanding, expressing, and regulating their feelings, but more particularly the negative feelings. So let's even just go back to the basics, just happy, sad, mad. Those are kind of the most ones that, you know, kids, especially little ones, know, but you'd also be surprised, even teens, it's like, you got 3-4 words that I kind of know what that is, when there's so many more emotions that we actually feel on a daily basis. But we can't even identify and understand the most basic. Imagine the negative ones. I don't know if you've ever been at a point in your life when you're like, I can't put a word to it. Like I'm mad and angry and upset and I'm nervous and anxious and all of it in one. So it's just, right? It's just, even us as adults, imagine our kiddos. Similarly, caregivers often experience a range of difficult emotions following a traumatic event. So in that healing journey for kiddos, especially when we're talking about child welfare and child maltreatment, they have had, and I'm going to focus a little bit here in a minute, in interpersonal violence or intimate partner violence, which we all kind of know more as domestic violence or family violence, which is why I say keep at bay. That statistics show that how many times are you going to come back to that relationship before you actually decide to completely leave? So that child is most likely going to be exposed to that again, right? The trauma narration and processing. So probably the hardest part for me, because I'm human, and doing this work is the trauma narration. But I mean, if you think it's hard for me, imagine the kiddo that's actually expressing this, vocalizing this, talking about this. So this is the part where they'll develop a narrative about their traumatic experience or experiences. What we focus in the trauma narrative part is it's kind of a free range. So the most common, you would think, it's a narrative, it's written. And while, more commonly we can journal, we can write it out, it actually doesn't have to be written. It can... I have had kids who are into rap music, and that might be an option. Nobody's taken me up on it. But they could do poetry, painting, drawing, acting it out, dancing it out, however way they want to talk, coloring it out for the little ones, right? Like they'll just kind of draw stick figures to kind of express and describe. It's their trauma narrative. And during that process, we work on correcting maladaptive cognitions expressed during that narrative, right? Like, it's because I'm a bad kid, so then this next scene happened, and it's because I'm bad, right? Or I did something bad. And so we work through that process, and I work with these kiddos, and helping them identify, now, is that what happened? Is that what's happening? And correcting those maladaptive thoughts. And we optimize the child's ability to discriminate between real danger and generalized fears. Because what happens in traumatic events is they become our reality. And it becomes really difficult to separate that from what is just a generalized fear and actually not real in that moment any longer. I will share that COVID hit right when we were about to go into the trauma narration process for one of my kiddos. And I mean, nobody taught us how to work behind a screen. And at least for me in therapy, from going to in-person, right, having that presence, having that connection, to, now we have this divider, this phone or this computer with all the buffering issues and inconveniences of it. And it's probably was the hardest, but most rewarding moments to be able to do a trauma narrative with one of my kiddos, telehealth. I say difficult because, man, I couldn't even be there to ask, do you need a shoulder? Do you need a pat? Do you want some Kleenex? That connection, I wasn't even there for that, right? But what an honor and a privilege to get to be there. Now, don't mind you, this kid was very much like, okay, let's just do it. And I was like, oh, you're ready. Oh, shoot, you're ready. Yes, I'm ready too. Let's get this going. And it was all the feels that you can feel. And one of those kids is probably the first slide that I talked about. Talking about what happened. So essentially what we do in that room, in that space, in that home, wherever we're at, is I'm going to be right here. You get to share with me and live. But there's a process. We don't start with trauma narration, right? We start with the education part. We start with the relaxation, the grounding. We start with make sure you identify. We do a lot of groundwork. We do a lot of that prep work before a kiddo is finally feeling in a space to say, it's time. It's time for me to get this out. And some take a little bit longer because there's still a lot of that, are you going to be safe enough for me? So after that, the conjoint child-parent sessions, now they kind of happen as all of the other stages happen, we do them. We still do parent-child sessions. We do parent sessions. It happens all along. It isn't like we just do kiddo, and then all of a sudden we just bring in the parent. No. So we work along, and I work along with the parent, the caregiver, the family, whoever that support system is. It can even be more than just one caregiver. Maybe it's the grandma and the tia, but they're the consistent ones showing up, right? So these joint child-parent sessions are where the child or the adolescent is encouraged to share their traumatic experiences directly with the caregiver. So the groundwork and the prep work is done with the parent. Remember, there's a lot of shame, there's a lot of guilt that happens as a parent. And we have to work with the parent to ensure, are you going to be in a space as well to receive when your kiddo starts telling you some of the details that you probably didn't want to hear, right? So significant caregiver preparation is usually necessary for the more intense and catastrophic traumatic experiences for these kiddos. And so this is to ensure that the parent is supportive and is validating those experiences for their kiddo. We come alongside the mom, the dad, the grandma, the tia, whoever, and we also validate that in itself was hard for them. How can we help them in this? Again, remember, it's supposed to be more of a shorter design. How in a shorter time frame can we equip you and help you kind of be to a place where you're going to receive what your kiddo has to give? And it also allows the parent the opportunity to practice those skills learned. And we are huge fans at FYI, shout out Michelle, my supervisor's here, so not extra nervous, that we come alongside these parents, but we model. We do what we call modeling, where, again, if you weren't taught how to do something, the likelihood of you implementing, from me giving you a worksheet and saying, this is what it looks like, this is what it means, all right, good luck. That's probably not going to work, right? So what does validating look like? What does being emotionally available for your child look like? So when we do our joint parent-child sessions, I will be modeling what emotional availability looks like. What highlighting, I just heard you say such thing. I'm thinking that this, and that. Thank you so much for that. And the parent's like, and then, not gonna lie, we're all human. Then we go, I'm like, all right, your turn. And the parent's like, yeah, come here. I see that so often. Earlier, I can't recall who was talking about the physical touch aspect of it, but most of my kiddos, I'll ask and I'll kind of assess for, what is that in your home, like the physical touch aspect? Are you guys huggers, kissers, high-fivers? Like, what are you? And they're like, what? So many of our kids and families, that was also not the norm in their homes. Again, I am a huge advocate for being very culturally aware and sensitive. So I'm a daughter of immigrant parents. I am first generation in the U.S. And so I grew up in a Mexican home. My native language is Spanish. And I had to learn English. And when I learned English, I was parentified because my mom didn't understand any of those forms or papers. And earlier in the other presentation I attended, like, why don't parents go to PTOs? My mom had no idea what that was. And if we went, I would just be translating everything and probably missing a lot of things because I was 7 or 8. Not fair, right? Those were my circumstances. So I also understand there's the limitation. There's a lot of fear. I was sharing, and I don't mind sharing this at all because it's my story, but my mom had a home birth because she was so afraid of being deported. And actually, a doctor wouldn't take her in because she was 8 months pregnant, and that's not legal anymore. Like, they can't do that. But over 30 years ago, that was, and she had a home birth with ibuprofen, and I'm over here, give me all the meds. And my mom, my mom did it with ibuprofen, but the circumstances, that was her only option in that moment. So a lot of the families that I work with, actually my entire caseload is Spanish speaking, but because I work with these families, it is just so interesting, but I also take it as a value to say, I'm going to meet you where you're at. There's a part in Tfcbt, the relaxation component. And can someone shout out, when you hear the word relaxation, what do you think of? Not all at once. Oh my gosh. Wait. Breathing. All right. Mindfulness. Those are all the really fancy terms that we know. When I try sharing that with this 70-year-old grandmother. Let's do some mindfulness. ¿Qué es eso? Mindfulness ni que nada. ¿Qué es eso? Pan con queso. No. So mindfulness, right? So we think of all these things that I think we have the privilege of knowing what those mean. But relaxation for a family maybe like that maybe comes through faith or spirituality. I've seen several families, they have their Bible, they have a rosary, they have a cross, and maybe for them, their mindfulness is, I'm going to go decir un rosario. I think, I'm not Catholic, but I've heard that. Or voy a orar, voy a meditar, I'm going to pray, I'm going to meditate. Those are all things we can incorporate and utilize. So just because our first thought is relaxation is, repeat after me, right? No. And although I try it, I offer that. Some families receive it, and they're like, oh, I didn't think breathing was so important. Yeah, it is. So is sleep and our food and all these other things, right? But we meet them where, at least I try to meet them where they're at, and we say, okay, what could we incorporate in this? And so there's a lot of skills that we practice with parents. Some are not received so well, so we try again. And in my practice, I have seen and found that it is more well received than not, because I'm allowing them to tell me their story, right? They're the experts in their lives. I get the privilege and honor to step into their home because they allow me to come into their home. It's a sacred place for them. It's a safe place for most of these families, their home. Whether it's on this side of town or that side of town, it doesn't matter. If they have a home or wherever they're at, that's a safe place for them. So these child-parent sessions are crucial. Enhancing safety and future development. This is how I'm getting a little bit more to the child welfare, and how does that tie into child maltreatment? So in this component, we ensure healthy child and family growth after treatment is over, so that there are practices in place, almost like a safety plan. And again, at bay, what's our thought at bay? That they might be exposed and probably will be exposed again to some type of family violence, right? The focus of sessions is enhancing that family communication and children's personal safety skills. So we kind of shift the perspective from, I'm just going to process what happened to me. It was a one-time thing. It won't happen, and hopefully maybe for some it won't. But we shift kind of that perspective to, how can we build on that? You're going to be that much more strong. Are you going to be able to overcome that? Are you going to build on what you have existingly right now? But I'm going to continue meeting you where you're at every step of the way. It's designed to minimize risk for future victimization and enhance feelings of self-efficacy and self-competence. So child maltreatment includes physical abuse, emotional abuse, sexual abuse, physical neglect, emotional neglect, exposure to interpersonal violence, intimate partner violence, amongst some other things. Just giving you a few numbers here in New Mexico. So interpersonal violence, intimate partner violence, emotional and physical abuse are primarily present in the families we serve within our child welfare continuum. There's other things. This is not encompassing everything. But about 19,000, a little over 19,000 law enforcement reported DV incidents in the latest data analysis done. Doesn't seem like a very high number, but then you look at the children reported at the scene, 6,718. To me, that's 6,718 too many. That's just reported. I've had some kiddos and parents come and say, yeah, here are several things that I can recall off the top of my head and share with you what happened. And I'm like, did anybody call the police? Did anything? No, we were too afraid. So that's just reported. There's so much more that goes unreported, right? 23% reported cases involving injury to children. So how can TFCBT help in the aftermath of child maltreatment? Again, it's adaptable and culturally sensitive and aware. So TFCBT is meant to, it's pretty structured, and if you're following faithfully, you see those outcomes. And I can say that I follow kind of that framework faithfully. However, the adaptability that I think I attempt to bring to these families is what really shows in the outcomes of, I'm not just an experiment. You're just going to try this modality on me. I don't go in and say, okay, let me teach you what TFCBT is. The psychoeducation part is about trauma. Let's talk about what happened and how that looks and how it shows up in your family. It has nothing to do with this actual title. So there's a shift in perspective as I come alongside both the child, the adolescent, and the supportive caregiver. I'll share. This grandmother wouldn't come to the meetings that we needed to have every month. She just wouldn't show up, wouldn't call me back, wouldn't answer. It was a lot of work. And then one day she answered or called me back, something of that nature. And I asked her, how are you? How are you feeling? She was kind of like, pues, Monday? She like, come again? You're asking me? No, well, this happened. And it was like deflected, right? Like, oh, no, you're calling to talk about my grandchild, right? I'm like, well, yeah, but it starts with you. How are you? You're in charge of this kiddo. And that's how I started that relationship with Grandma. And she started showing up. She started actually contributing. And not because she was, and here's the misconception that I think I want to encourage you to challenge yourself in your practice is that, oh, well, they just don't show up. They're neglectful. Oh, well, they just don't want to. Oh, they don't understand. There's a language barrier. Grandmother's age. There's 5 other children in that home. Immigration, poverty, only primary caregiver, nearly 70 years old. There were so many complicating factors that it wasn't that grandmother didn't want to show up. Sometimes she literally just couldn't show up. So shifting that perspective to you are a person. Client-centered to also including the support network consistently. So the other thing is we can't do this alone. I heard the word casualties earlier, and I wish there wouldn't be any, but sometimes there are because we have those kiddos like at that age of consent right at 14 where they're like, don't want my mom involved, don't want my dad involved, don't want my caregiver involved, and we're kind of like stuck. And so we maintain and we help them until hopefully they become and go into adulthood, hopefully better. But it shifts it from just being about the kiddo to including as much as we can that support network. It addresses shame, guilt, and self-blame from a cultural lens. El que dirá. Did someone speak Spanish in this room? El que dirá means what will they say? The criticism of others. It's very embedded. Aquí en esta casa se queda. Here what happens, it stays. It does not go out because there's shame and there's guilt and there's judgment and all these things if it got out. Right? We don't air our dirty laundry, as we say here. So trauma narration and processing, it doesn't always focus on mastering past trauma-related memories, but like I said, optimizing those child's strengths and coping and strategies on how to overcome should they be in that position again. So, that's the end of my presentation. Any questions? I do want you to ponder on this. While in a perfect world, we would, at least for me, I should speak for myself, I would do away with all of that child maltreatment. I would do away with all of the neglect. But more so, I think my heart is placed that I would do away with all of the misconceptions of what it is to talk about what we've gone through, what we've done. So in my experience, what I've dealt with, what I've gone through, I have a lens where I have the privilege to say, I use the past, for hope for today. What happened to me, and so we instill hope. And at least in my practice, I hope to be that instiller of hope in these kids, that maybe there will be another intimate partner violence accident, incident, season of life for them. But somewhere along the line, someone planted that seed that reminded them that they can do the work. And we're going to come alongside them. We're in the trenches with them. And in my practice, in utilizing TFCBT and seeing how that intersects in child welfare, and why we've seen some really, I think, positive outcomes even within our community-based programs, is that we are those toiling in the service of others within their homes, figuratively and literally within the homes of these people. So, any questions about this model in particular, the work? Not todos, not all at once. No? Thank you so much for coming and giving me your time. Appreciate it.